Good morning, everybody. Right? Yeah, I hope you all can hear me. I think it's still Hari Raya, right? Still Hari Raya month, so happy Hari Raya to all those celebrating. So today, the first topic for today's breakfast at will be done by my colleague here, Professor Benedict Francis. Okay, he'll be talking about mood disorders in the older population. Dr. Benedict is a consultant psychiatrist and researcher at UMHealth, Department of Psychological Medicine, with a passion in clinical trials and psychiatric research. He has published numerous papers in international journals and has been involved in several advisory boards, as well as steering committees related to mood disorders and schizophrenia. And here in PPUM, he actually runs the geriatric psychiatric clinic. So he's very well versed with treating the older patients with psychiatric illnesses. So without further ado, I will pass the screen to Dr. Benedict.
Okay, so good morning, everyone. So the topic today that I would like to share with all of you all is something that is quite close to my research interests and my clinical interests as well. So I'd like to share with you all on the topic of mood disorders in older persons. Now, just to share with you the outline of my talk, we'll start with a little bit of an introduction to mood disorders in older persons, with a spotlight on late life depression and also late onset bipolar disorders. Well, as you know, we are increasingly becoming an aging population. So here in Malaysia, the statistics is quite sobering. We are bound to be an aging nation by 2030, actually. And you know, at the present times, there are already more older persons than there are children. And by 2030, we estimate that 15% of our population will be aged 60 years and above. Okay, so this means that we are going to be dealing with a lot more older persons' health-related issues. And this also includes mental health issues such as depression. Now, the latest National Health Morbidity Survey done in 2019 stated that 1 in 3 Malaysians actually have symptoms of mental illness. And this also includes the older persons. Okay. So when talking about late life depression and also late onset bipolar disorders, these are associated with several things that needs to be noted. The first one is increased amount of medical comorbidities such as diabetes, hypertension, and other chronic illnesses. In fact, late life depression has a bi-directional relationship with medical comorbidities. These disorders have also been associated with cognitive decline. If the disease are not treated promptly, it may lead to cognitive frailty and also worsening of cognition with time, even predisposing to dementia. There's also the increased risk of suicide, as we know that suicide risk increases at both extremes of age. So those who are young and also those who are older, there is an accentuated risk of suicide, and of course increased mortality if these disorders are not treated well. Now, late life depression is actually a leading contributor of geriatric morbidity because it's often treatment resistant, it's not recognized early enough. And in my clinical practice, you know, when the patients present, they are already quite advanced in the spectrum of illness and oftentimes not very responsive to antidepressant treatment. So there is a need to increase awareness to these conditions so that they come and see us early for us to institute prompt treatment. And it's associated with cognitive impairment in more than half of the cases and linked to twofold increase in developing several types of dementia, particularly Alzheimer's disease and also vascular dementia. Now, talking about depression in Alzheimer's disease, actually the point prevalence of depression in Alzheimer's disease is about 15 to 16%, which is quite a high rate. Now, just comparing the epidemiology of both these mood disorders, looking at late life depression, the prevalence actually can go up to more than 30% in some community studies. Okay, whereas for late onset bipolar disorders, the prevalence a little bit more modest, so between 0.1 to 0.5%. But I suspect the high prevalence for late life depression is also because they were not strictly following the categorical definition of DSM-5, but merely looking at symptoms of depression amongst older persons. Now, both late life depression and late onset bipolar disorders were more female predominant. Both were associated with cognitive deficits, although early onset bipolar disorder actually had more cognitive deficits compared to late onset bipolar disorders. Both were associated with a certain amount of treatment resistance, and this is quite understandable because as the brain ages, it's not very receptive towards medication because there's change in neurotransmitter balance and also receptor distribution. Okay, and of course, both these conditions are under-recognized, and there's a lot more research that needs to be done to understand these conditions better. Now let's compare adult onset versus late life depression. Now, late life depression is actually defined as the onset of depression beyond the age of 60. Okay, and if you compare both adult onset and late life depression, of course, in adult onset depression, there's more genetic factors that could predispose them towards developing depressions, such as serotonin transporter gene variations or certain kinds of mutation. Whereas in late life depression, we don't really see a strong genetic factor, but there are more structural changes in the brain. For example, more white matter, hyperintensities, and also changes in the sizes of the hippocampus and amygdala. Adult onset depression can begin in childhood. As I said earlier, on late life depression usually begins at age 65, or sometimes use the definition of 60 years and above. In young adults who have depression, they're more likely to seek treatment. Okay, whereas those with late life depression, it's quite difficult for them to admit, first of all, that they are depressed. They are not likely to seek treatment, and they are constantly in denial because sometimes they may not even realize that they are depressed. Oftentimes, their depression is somatized into all kinds of physical symptoms, for example, gastritis, headache, and also muscle ache. I've had a patient who's had chronic headache with constipation to eventually be diagnosed with persistent depression after all the organic workout turned out to be negative. Okay, there's greater substance abuse in young onset depression compared to late life depression, and of course, higher load of cognitive burden in late life depression. And as you know, late life depression is also strongly associated with the development of dementia. In fact, the presence of depression has been shown to increase the risk of dementia by 2 to 3 times. Okay, there's lesser psychomotor retardation with adult onset depression, but more pronounced psychomotor retardation with late life depression, and this is part of the dysexecutive syndrome disorder, which could be a part of late life depression. So there are some other features of late life depression that needs to be highlighted. They present with more of the following: they're more fatigued, more sleep disturbances. So they either awaken earlier or they have increased amount of sleep. But usually in my clinical practice, I find that insomnia seems to be the more common presentation. Hopelessness tends to be stronger, and this is associated with both passive and active suicidal ideations. There's a lot more cognitive complaints. Now, I oftentimes teach my trainees that when the patients complain of cognitive problems, is more often to be mild cognitive impairment. But if they do not complain of these cognitive problems, but their caregivers complain on their behalf, then it's more likely to already be going towards frank dementia. There's also some amount of psychomotor retardation, and sometimes they present with a lot of apathy. And it might be difficult to distinguish from certain types of dementias, for example, atypical Alzheimer's disease. Now, as I mentioned earlier on, depression has a bi-directional relationship with medical illnesses. The presence of depression can worsen medical illnesses. For example, it may worsen the presence of obesity, frailty, diabetes, coronary artery disease. And this is because depression is a state of inflammation. There's a lot of inflammation going on in someone with chronic depression. And there are studies that have showed that untreated depression is actually lead to accelerated rates of atherosclerosis, thus increasing the risk of coronary artery disease and also cerebrovascular disease. And of course, the presence of medical illnesses can be complicated by depression. And we do know that patients who are depressed, they don't take care of their health, they don't come for their follow-ups, they don't maintain a healthy lifestyle, and this can worsen a lot of chronic illnesses, including autoimmune diseases and also other forms of endocrine diseases as well. So oftentimes you see that patients with chronic depression also have subclinical hypothyroidism, and this can worsen their presentation. Now, looking at the mechanisms of late life depression, it's a little bit different from young onset depression. In young onset depression, the focus is really on the neurotransmitter imbalance and also focusing on the monoamine hypothesis, whereby there's an acute lack of serotonin and dopamine and norepinephrine. But when we talk about late life depression, we are looking into more of the neural circuitries in the brain and how these circuitries are actually disordered. And one important neural circuitry in the brain that is disordered in late life depression is the frontal limbic circuit, which controls pleasure, reward perception, and also salience interpretation. And when this circuitry is disrupted because of chronic inflammation, ischemia, and also white matter hyper intensity, the older person is unable to interpret pleasurable stimuli, and there are a lot of cognitive biases. Okay, so you can see here that late life depression has a strong link with their general health well-being, because with increased inflammation, we find that there is more dendritic remodeling, there is a lot more oxidative damage to the brain, and there is a reduced amount of neurogenesis with eventual altered functional connectivity, especially at the frontal regions of the brain. Now, I was telling you earlier on about this syndrome, which is quite specific to older person. It's called the Depression Executive Dysfunction Syndrome, also known as DED syndrome. And this syndrome affects about 30% of older persons, which leads to poor response to antidepressants. Now, this particular syndrome is characterized by a significant amount of apathy, psychomotor retardation, presence of anhedonia, pronounced disability. They may lose some amount of ADL abilities. There are mild vegetative symptoms. They may not want to eat, drink, and sleep may be affected. And there's some amount of suspiciousness, quite interestingly. And we see some similarities with paraphrenia that is sometimes seen with old age. And less pronounced depressive ideations. Okay, so they are less likely to come forward and say, I'm depressed, but rather they may present in other subtle ways. So it's important for the clinician to be able to identify this and make a prompt referral to the psychiatrist, because if untreated, this executive dysfunction syndrome can very quickly slide into a more could quite easily slide into a more severe form of cognitive impairment, such as the development of dementia. And this syndrome has been related to disruptions, again, to the frontal subcortical networks. So we see some amount of similarity also with patients with vascular dementia, whereby these patients also have a lot of apathy, psychomotor retardation, and executive dysfunction. And I think the similarity between these two syndromes or these two disorders is that both have quite significant white matter damage in the brain. Now let's talk a little bit about the inflammation hypothesis of late life depression. We know that aging is associated with pro-inflammatory changes. We've done studies showing that there are increased levels of inflammatory markers, particularly IL-1, IL-6, and also TNF-alpha. And there's been some efforts in trying to treat depression using NSAIDs, but of course, these efforts have failed. But that does not reduce the fact that there is a lot of inflammation going on in depression, and over time, the persistent activation of microglial tends to lead to a lack of synaptogenesis, and there's also loss of neurons. And when there's lesser crosstalk in the brain, the brain is more likely to enter into a treatment-resistant state. And how do we reduce inflammation in the brain? This again goes back to lifestyle changes. So the kind of foods that we eat, exercise that we undertake. Now there's research showing that exercise 3 times a week, at least half an hour each time, has been associated with increased quality of life, reduce depression, and also in schizophrenia as well. They've showed that exercise can improve cognition. So exercise has a lot of benefits and ultimately leads to a pro-cognitive state. Now, there is a lot of overlap between late life depression and also dementia, especially Alzheimer's dementia. And we find that depression is associated with increased amyloid beta load in the brain. There's one study that followed up patients over a 5-year period, and using PET scans, they found that there was increased amount of amyloid beta deposition at the end of the 5-year period in those who were depressed compared to those who were not depressed. If you look at the normal rates of conversion between amnestic MCI to Alzheimer's dementia is between 15 to 20% a year. And being depressed actually accelerates this rate of conversion. Okay, so if you have depression and you have MCI, you're highly likely to develop frank dementia. And the deposition of amyloid beta in this subgroup of patients are mainly seen in the frontal cortex and also in the temporal and parietal lobe. Now, how do we treat late life depression? So despite what I said earlier on, that patients with late life depression tend to be more treatment resistant compared to the younger counterparts, late life depression still responds quite well to antidepressant therapy. Okay, so we can use the standard antidepressants that we have with us. We can use SSRIs, SNRIs, but we also may need to augment some of this treatment with other agents, for example, lithium, partial agonists such as aripiprazole or cariprazine, and sometimes even low doses of psychostimulants such as Ritalin, I find quite efficacious as augmenting agents. Okay, we also find that using antidepressants early actually can reduce the amyloid load in the brain. This again has been shown by PET studies, okay, in neuro imaging research. Okay, and there's some findings that using lithium as an augmenting agent in late life depression may delay the onset of Alzheimer's disease. Okay. That said, using antidepressants are not as effective in treating the depression of dementia. Okay? But of course, clinically, we still use antidepressants, but they may not be as effective once they have already developed dementia. Okay. I find that sometimes doing ECT in older patients can actually be quite efficacious, although you need to think about the cognitive side effect. But according to research, it's actually one of the most effective therapies in late life depression, and results in a remission rates of 60 to 80%. It is safe and efficacious in late life depression, especially with patients who have accompanying stroke, Parkinsonism and even mild dementia. There's some evidence that shows that. And we find that the mean number of ECTs to achieve remission was about 7. Okay, so there's a lot of people who are very hesitant in using ECT for older patients, but I've actually had good experience in doing that. You don't necessarily have to put them on right unilateral. Okay, you can start with doing a bitemporal ECT, and only if there's risk of cognitive impairment, you can switch to doing a right unilateral lead placement. Okay, so I find that using ECTs judiciously actually can prevent the side effects that results from polypharmacy in these patients, because with late life depression, one tends to layer on a lot of medications for them because they usually don't respond to just one medication, and you need to add on an antidepressant, a mood stabilizer, sometimes an atypical antipsychotic, and the risk factor of all these medications combined actually a lot more than the risk of administering ECT for these patients, which is fairly safe. Now, not forgetting the non-pharmacological approaches to late life depression, of course, there is the CBT, which is the most evidence-based form of psychotherapy in patients who are depressed. Of course, we want to psychoeducate them about the problem. We want to give caregiver support. Caregiver burden is another issue that needs to be tackled in patients who are depressed. There's a lot of effort going into caring for the older person who is depressed, and this can also take a toll on the mental well-being of the caregiver. Interpersonal therapy has also been shown to be effective in alleviating depression in older adults. We also want strategies to stimulate the cognition in older adults. So this can be in the form of exercise, can be in the form of daycare, can be in the form of joining social clubs. So I often find that loneliness also is a huge factor that tends to perpetuate depression. So we need to find ways to occupy our older adults, and I think there are some online initiatives now. For example, the University of Third Age that actually provides ample resources for older persons to occupy their time. Now let's just segue to late onset bipolar disorder now, which is a lot less common than late life depression. So the prevalence is between 0.1 to 0.5% amongst older adults that are aged more than 65 years old. Okay, and as I said, not so likely. According to the epidemiological catchment study, we found that depression and schizophrenia are actually 14 times more common in older persons compared to bipolar disorder. And this could lead to this disorder being less identified in our older adults, or being identified quite late, which makes the treatment not so good for this group of patients. Okay, it's associated with more neurological impairments. Substance issue is less often comorbid compared to younger onset bipolar disorders. They tend to have more mixed features, okay, which means that if they have a manic phase, it could be mixed with a little bit of depression, and if they present with a depressive illness, it could be mixed with a bit of hypomanic, also manic symptoms. There is lower amounts of genetic loading in patients with late onset bipolar disorders, but amongst the family members of those with late onset bipolar disorders, it has been shown that they have a 50% risk of developing an affective disorder. Again, similar to late life depression, there's greater cortical atrophy and also white matter hyperintensities with late onset bipolar disorders. Now, most of the late onset bipolar disorders belong to a category called secondary mania. This is differentiated from primary mania because secondary mania is usually secondary to an organic cause, most often a neurological cause, whereas young onset bipolar is because of so-called mental illness per se. So it's part of their bipolar disorder. Okay, so the first thing to do when we want to assess or we want to approach someone with secondary mania is to look hard for an organic cause. And in fact, 71% of older persons with mania had a comorbid neurological disorder, and after a stroke, actually there is quite a high risk. Actually, in fact, I think there was one study that showed that in those patients who have developed a stroke, the risk of developing mania increases by 3 to 4%. And these are the brain lesions that are usually associated with mania. So if you look at it, a lot of it is on the right side of the brain. So they found that lesions at the right side of the brain more associated with mania, lesions on the left side of the brain more associated with depression. And these are the areas that are usually affected: the bilateral orbital frontal areas, right temporal parietal, the medial temporal lobe, right frontotemporal lesions, and also Binswanger's disease, which is a form of small vessel disease sometimes seen in older persons. So mania could be a prodrome of dementia in older persons. It could also be the presenting features of some forms of dementia, particularly frontotemporal dementia. So if someone who in their 50s come in with hypomanic or even manic symptoms, for example, disinhibition, increased energy, spending spree, they have to be worked out for possible frontotemporal dementia before late onset bipolar disorder diagnosis is instituted. Okay, I always say that late onset bipolar disorders is a diagnosis of exclusion. You got to exclude a lot of other organic pathology so that we can some of these organic pathologies may even be reversible. So we need to look hard for them. Okay. Now, how do we do the assessment for late onset bipolar disorders? Of course, take a thorough history, be inclusive. I would always have a discussion with my colleagues from other departments, because we want to include, we want to consider other organic disorders, particularly neurological disorders. And as I mentioned earlier, is often a diagnosis of exclusion. Now, speaking also a little bit about the relationship of dementia with late onset bipolar disorders, there was a systematic review that concluded that patients with dementia actually have a nine times more likely, actually, those with dementia with high vascular burden are 9 times more likely to develop late onset bipolar disorders compared to those without dementia. So what are the considerations for pharmacotherapy in older persons? So they have reduced capacity to metabolize drugs. Obviously, their liver function may not be the best. They're more sensitive to medication-associated side effects, more drug-drug interactions. There may be the presence of other age-related psychosocial problems such as frailty. They may not be able to come for their appointments. So we may need to include community psychiatry, so that these patients may be visited at their homes instead of expecting them to come over. So again, looking at all these considerations, we really want to focus on monotherapy rather than polypharmacy, because we also want to reduce the risk of falls in this group of patients. Okay, so in terms of treatment, we oftentimes give a mood stabilizer with atypical antipsychotics. I personally prefer sodium valproate due to its better safety profile. The dose range up to 1,000 milligrams in a day. You can give it in split dosing. I would use lithium very, very cautiously, because it can precipitate thyroid dysfunction, and those with poor renal function can also worsen renal status. And over the past couple of years, I've seen a few patients who've actually developed encephalopathy with lithium. I've seen some older patients with bipolar develop encephalopathy because of excessive lithium being used. Okay, if using lithium, the dose should be reduced by 30 to 50%, and we want a target level that is a bit lower compared to younger adults. We're looking at between 0.4 to 0.7 millimoles per liter. And we have to remember that older adults are most sensitive to medications, and thus our mantra should always be start low and go extremely slow. I just want to share with you one research that I did some years back, looking at the impact of ECT in a 91-year-old Asian lady with late onset bipolar mania, just to illustrate to you that ECT is very, very safe. And we managed to publish this in the Asian Journal of Psychiatry, showing that ECT was in fact efficacious in this 91-year-old lady with late onset bipolar. And we actually managed to bring her into remission after instituting. In fact, we did bitemporal ECT for her. Okay, with that, thank you very much. More than happy to take any questions if you have them.
Thank you very much, Dr. Benedict, for the excellent presentation. Okay, so since we are running out of time, we have one question here in the question box from Dr. YK Chan, Professor YK Chan. Would institution of exercise after depression and dementia reduce or even reverse the signs and symptoms of late life depression?
Yes, thank you for the question. Yes, exercise has been shown to reduce the symptoms of depression. Also, it can be used as an excellent prophylaxis to prevent the development of depression. It is the pro-cognitive benefits of exercise have also been demonstrated numerous times. So I would prescribe exercise actually to my older patients. What I usually tell them is that 3 times a week, at least half an hour each time, just mild cardio, not excessive cardio, but not only cardio, but also doing balance training. So they could do, for example, just even things like chair yoga for those who are not able to ambulate, and just doing some strengthening exercises. They could carry a small weight, or they could just they could stand on tiptoe. They could do some mild stretching exercises, not necessarily cardio, but even stimulating movements can also be an effective form of exercise for older persons. And even these slight movements over the long run can reduce inflammation in the body. And inflammation is, I think, now central to a lot of pathologies, and mental illness is not excluded.
Thank you, Dr. Benedict. Since it's sharp 8:30, there's one last question from Prof. Pusara. right? So I can just answer very short.
Okay.
30 seconds answer because we are due for the next talk. Is this due, I guess, is late life depression due to brain inflammation or does it cause brain inflammation?
Yes, excellent question, Prof. Well, both, I would say. Being depressed is associated with a state of inflammation in the brain, and of course, having untreated depression worsens the state of inflammation. So I guess the best thing to do is, from the very get-go, trying to enter into a state that reduces inflammation in the brain. So we want to focus on lifestyle factors. So the kind of food that we eat, actually, I think is very, very important, and that can actually reduce the likelihood of one developing depression in late life. And there are studies showing this as well. If you were to keep to exercise and dietary modifications, we find that those living in the Mediterranean area and those consuming those kind of foods that are high in healthy fats and also certain types of fish, for example, salmon, they have very little inflammation and therefore have lower rates of dementia and also depression in those populations.
Thank you very much. So once again, thank you, Dr. Benedict, for the excellent talk, and which was very clearly presented. So since time is up, I would like to share the virtual floor to our next moderator, Prof. Halim.